Hi, today me, Anis, and my group mates Fakiha, Marisa, and Tulashni are going to present our seminar topic, which is the visual aids in diagnostic pathology. So our learning objective is to list the various visual aids used in diagnostic pathology. So the most important visual aids that we're going to discuss today are Valscope, Visilight Plus, Microlux DL, and Raman spectroscopy. So moving on to the first aid, which is the veil scope. It is also known as visually enhanced lesion scope. It uses direct optical fluorescence visualization technology, and the uses of veil scope are to visualize unhealthy mucosal tissue that cannot be seen with naked eye, and it is an adjunctive aid for non-invasive oral cancer screening device. However, veil scope cannot replace oral examination and scalpel biopsy, which remains the golden standard of diagnosis. So before I'm going to explain how veil scope works, we have to know that each cell in the human body contains molecules capable of autofluorescence, which is caused by the fluorophores. So when these fluorophores are excited by light of an appropriate wavelength, for example blue, they will emit their own light at a longer wavelength, for example green. And examples of fluorescent components are NADH, FAD, tryptophan, porphyrins, collagen fibers, elastins, and flavins. So Valscope works on the principle of visual autofluorescence, and it emits blue light with a special wavelength of 400 to 416 nanometer as the source that penetrates the epithelial layer and the basal layer, reaching the stroma. It will stimulate the fluorophores within the mucosal tissue, causing them to emit a fluorescent green glow, and a special optical filters in the handpiece will allow the clinician to view the different fluorescence responses of healthy and abnormal oral tissues. So from this picture, we can see that when the veil scope emits the blue light, the normal cell will produce normal fluorescence pattern as they have normal amount of fluorophores. Unlike these abnormal cells, which have lower amount of fluorophores, they will lose the normal fluorescence pattern. Then the procedure on how to use the veil scope is, first we have to turn off the ambient lights and then direct the unit light at the oral tissue. Then observe the fluorescence response through the special optical filters. So from this picture, we can see that one end of the veil scope is where the blue light is emitted onto the oral mucosa, and the other end here is where the special optical filters are present, from which the clinician will look through it. So this is how it will appear through the veil scope. So for the interpretation, normal cells will appear bright green, while abnormal cells, which are not necessarily only cancer or precancerous cells, they will appear dark like black or black greenish or black bluish because they produce lower amount of NADH and FAD, which are one of the fluorescent components. So this is the appearance of palette with the naked eye, where we can't actually visualize any unhealthy area, but then through the veil scope we can make out the dark area, which later by biopsy it is confirmed as oral cancer. Moving on to advantages and disadvantages of veil scope. So advantages of veil scope is it is simple to use and time saving, it is portable and easily stored. It is exceptionally painless for the patient. Veil scope is safe from the cross-infection perspective, as usually it is supplied with plastic protectors for its lens and plastic sleeve for the body of the machine. And the light used penetrates to the deepest layer of epithelium, thus it reaches easily the dysplastic cells of the deeper epithelium layers, as well as the subepithelial collagen fibers. So, and the disadvantages of veil scope is it is not diagnostic, it is only for screening purpose. It cannot determine whether or not the lesion is cancerous. False positive result due to change in blood circulation, inflammation or infection. So in case the clinician is highly suspected of inflammation and infection in origin, usually they will ask the patient to come again after 1 to 2 weeks for re-evaluation. And lastly, practitioners require more training and experience with the device as well as mucosal pathology to prevent incidents of false positive results. So the recent and most advanced Velscope technology is the Velscope VS Enhanced Oral Assessment System, where the advantages are it is cordless and lightweight, making it exceptionally portable. It is cheaper roughly by half price, and the eyepiece of the device can be adapted to a camera, hence able to obtain images of the tissue, which by obtaining the image, the changes can be demonstrated to the patient and can be further analyzed by the clinician. So I pass the floor to Fakiha.
Hi, now I'm going to talk about VisiLight. VisiLight uses the principle of chemiluminescence-based detection device. It is to facilitate early identification of pre-malignant disease and oral squamous cell carcinoma. Oral cancer is 90% curable when found in early stages as per literature. Chemiluminescence enhances subjective clinical evaluation of intraoral lesions including brightness, sharpness, and texture with respect to routine clinical examination. The VisiLight Plus is the combination of chemiluminescence and toluidine blue marking system. It is an acidophilic dye that selectively stains acetic substance such as DNA, which can be found in the nucleus. VisiLight Light Stick is a disposable capsule formed by an outer shell of flexible plastic containing acetyl salicylic acid and inner gas vial containing hydrogen peroxide. To activate the light stick, the capsule is bent to break the inner glass vial, triggering the reaction of the chemicals contained in two compartments. It will produce blue-white light of 430 to 580 nanometers of wavelength which lasts for 10 minutes. Toluidine blue 630 is the only patent pharmaceutical grade form of toluidine blue under Zilla Pharmaceuticals. It is known as Zilla toluene chloride. This toluidine blue consists of 3 swab components which is labeled 1, 2, and 3. There are 2 swabs of 1% acetic acid rings including post-dye decolorizer, 1 swab with metachromatic vital tissue dye, toluidine blue which provides deep blue staining that allow luminoscopy identified lesion to be clearly seen under the normal light. It also comes with accessory eyewear which is to allow better isolation of chemiluminescent light. The procedure of the VisiLight is the lesion has to undergo 1 minute rinse of 1% acetic acid solution to remove glycoprotein barrier and desiccate the oral tissue to increase visibility of epithelial cell nuclei. Oral examination using chemiluminescent light source of 430 to 580 nanometers wavelength is done. Bend the flexible outer light stick to break inner brittle vials so that the hydrogen peroxide can undergo chemical reaction with 1% acetic acid. This is to activate the light stick. Then shake vigorously and insert the light stick into open end of retractor and assemble. Dim the lights in room or use eyewear provided to facilitate with examination. Look for any abnormalities of the oral cavity and document it. If the lesion is found positive, which shown aceto-white lesions under the chemiluminescence light stick, apply toluidine blue marking system. The swab should be applied in sequential order. The swab tubes are individually labeled 1, 2, and 3. These are the procedure. The first picture on the left shows bending of the light stick to activate it. The second picture on the right shows examining of the oral cavity using VisiLight Plus device. And the next picture shows application of toluidine blue marking system to lesion visible under the VisiLight Plus illumination. And the picture on the right shows a lesion which is stained with toluidine blue, which indicates there is this plastic features on the lesion. The results of the VisiLight is it shows aceto-white lesion for a positive results which due to altered epithelial cells due to high N/C ratio, and dehydration with acetic acid highlights the nuclear density. Thus, it reflects the light. A normal epithelium will absorb the light and appear dark. The result on the use of toluidine blue 630, it shows blue on this plastic lesion because it has been proposed that living cells will differentially accumulate toluidine blue based on metabolic activities of the cell. Here, the picture shows how luminoscopy works. Normal cell or tissue which is on the stage 1 will absorb the light, thus it appears dark. Meanwhile, the abnormal cells of tissue will reflect the light at stage 2, 3, and 4, and thus it appears as white patch or known as aceto-white. These are the advantages of the uses of busy light. The first one, it shows a brighter and better demarcation of lesion than using incandescent light. As we can see the picture at the bottom, the picture A shows the lesions under incandescent light, and the picture B shows the lesion under chemiluminescence device. Next, the advantages are easy to use, it is non-invasive and a chairside task, it is a single-use material, can be conveniently disposed, hence it will eliminate the risk of cross-contamination. It is also easily storable. There are also a few disadvantages by using busy light. It is less useful to detect malignancies in a clearly visible lesion. Clearly visible lesions such as PVL, proliferative verrucous plaque, or verrucous carcinoma, which can be seen clearly with naked eyes. It also has limitation in diagnosing oral squamous cell carcinoma, as it identifies dysplastic areas rather than hyperkeratosis. It also cannot discriminate between progressive and non-progressive counterparts tumor, and the highest reported specificity of luminoscopy is only 14.2%, which is quite low, and it is not economical as the price of one test can cost nearly 50 ringgit or 1,000 rupees. Other tests that can be found as more cheaper in price.
Alright, so next I'll be explaining more about Microlux DL, DL meaning diagnostic light. So Microlux DL is a battery-powered diffuse blue-white LED light source which is used for the examination of oral mucosa. This device is used as an aid to improve the visualization of oral lesions. Rinsing with 1% of acetic acid solution together with the diffused light from the Microlux DL light guide helps abnormal lesions to become more visible. It is to be used in conjunction with a traditional visual and tactile examination. The exam is performed by a dentist or a healthcare provider to increase the discovery of abnormal lesions found on the soft tissues of the oral environment. So here are some pictures of how the Microlux DL looks like. Next, we move on to the procedure. Microlux DL is based on the principle of tissue reflectance. In this technique, the patient rinses with 1% of acetic acid solution for 60 seconds in the oral cavity. The acetic acid rinse eliminates surface debris and dehydrates the epithelial cells, which causes their nuclei to appear prominent. The room light also should be lowered at the start of the procedure. Next, the oral cavity is then examined with the help of blue-white light, which is around 440 nanometers, generated by a battery-operating light-emitting diode fiber optic source. The light-emitting diode transilluminator is an autoclavable light guide that produces diffuse light. The normal epithelium will visually appear as light bluish, whereas the abnormal epithelium as a distinct aceto-white. Next, we move on to the advantages of Microlux DL. It is autoclavable and it has high output LED. It is also battery operated, portable, and easy to use. Next, it helps to visualize remaining composite removal, crown fractures, and also root canal orifice. A recent study also concluded that Microlux aids in the diagnosis of oral pre-malignant and malignant lesions. Next, the disadvantages of Microlux. DL, Microlux DL does not distinguish between benign and malignant lesions. However, it increases the probability of detecting the lesion and revealing new lesions when compared with conventional oral examination. It also does not provide any indication of the underlying pathology of mucosal lesions.
My name is Tulashini. Renal spectroscopy is a non-destructive chemical analysis technique which is used to analyze vibrational, rotational, and other low-frequency nodes in a system, providing information about chemical structure, crystallinity, and other molecular interactions. How does renal spectroscopy work? When a monochromatic radiation of a definite frequency is passed through a substance, the light is scattered at right angles to the incident radiation containing lines of incident frequency, certain discrete frequency above or below that of incident radiation. The transmitted lines of the same frequency as the incident radiation is called as Rayleigh scatter. However, a small light scattered at different frequency is called Raman scatter. What is the application of Raman spectroscopy in dentistry? It can be used for analyzing tooth structure, a comparison with synthetic appetite. It can also be used as oral heart tissue pathology. It can be used for diagnosing early dental caries, as you can see in the picture below, and it can also be used in diagnosing developmental disorder of enamel and dentin.
Now, we're going to discuss on the extended learning topics, which are the pulp vitality test, vital staining, Schirmer test, biopsy, plain radiograph, CT scan, CBCT, MRI, autofluorescence, and scintigraphy. So moving on to the first one, which is the pulp vitality test. The function is to determine the vitality of tooth and pathological status of the pulp. There are two methods for pulp vitality test, which are the first one, the neural sensibility test, which is more common, and then the second one is pulp vascularity test, which is more accurate. So for neural sensibility test, it indirectly tests the vitality of pulp, where they work on the principle of stimulating neural fibers of the pulp. While for pulp vascularity test, it confirmed the true vitality status by assessing the blood supply to the tooth. So the example of neural sensibility test, we have the thermal test, which includes heat and cool test, electric pulp test, anesthetic test, test cavity, and bite test. For pulp vascularity test, we have pulse oximetry, laser Doppler flowmetry, dual wavelength spectrophotometry, thermography, ground surface temperature, and transmitted light photoplethysmography. For neural sensibility test, we have the heat test here. It is done by applying the heated gutta-percha stick to the tooth surface. For the cold test, it is done by applying the cotton pellet soaked in the endo ice onto the tooth. For anesthetic test, it is done by anesthetize a single tooth at a time until pain disappears. For bite test, it is done by asking the patient to bite on hard object such as cotton swab, toothpick, or orange wood stick. And this test is done if the patient complains of pain on mastication, hence helps to identify cracked or fractured tooth. For the test cavity, it means that we have to drill through the dentino-enamel junction of an unanesthetized tooth, and a painful sensation indicates some vitality present in the pulp. For the last test is the electric pulp test. It is done by placing the electrode against an isolated and dried tooth crown using a toothpaste as an electrolyte. And in anterior tooth, it is placed on incisal third, while in posterior tooth, it is placed on the middle third. So for pulp vascularity test, the first one we have the pulse oximetry here, where it measures the oxygen saturation level. The pulse oximeter sensor, it consists of two light emitting diode, which one of it is to transmit the red light and the other one they transmit the infrared light. And we have a photodetector on the opposite side of the vascular bed, or in this case the tooth. So this light emitting diode, they will emit both red and infrared light through a vascular bed, and oxygenated and deoxygenated hemoglobin will absorb different amount of red and infrared light and this absorption is analyzed by the pulse oximeter to determine the saturation of the arterial blood. The second one, here we have the laser Doppler flowmetry. It measures the rate of blood flow in a tissue, and it is based on Doppler principle, in which low power light from a monochromatic laser beam of known wavelength along a fiber optic cable is directed to the tooth surface. Just imagine. And the light that contacts a moving object, for example here RBC in the pulp, is Doppler shifted, and a portion of that light will be back scattered out of the tooth into the photodetector and continue to the and transmitted to the computer for analyzation. So the next test is the vital staining. Vital staining is a procedure where living cells take up certain dyes which selectively stain some element in the cells like mitochondria, nuclear material, etc. There are two types of vital staining. The first one is the intravital staining, which is done in vivo, and the second one is supravital staining, which is done in vitro. Examples of vital stains that can be used are the toluidine blue stain, Lugol's iodine, methylene blue, rose bengal dye, and acetic acid. So the most common stain that we use is the toluidine blue stain. It is also known as toluenium chloride, methyl aniline, or aminotoluene. The uses is to determine the degree of suspicion with regard to specific lesion, and it determines the best area of tissue to be biopsied. Toluidine blue staining consists of 1% toluidine blue dye, water, and 1% acetic acid solution. Moving on how it works, toluidine blue is an acidophilic metachromatic dye which has the ability to bind to acidic tissue components like the nuclear material, DNA, and RNA that are undergoing increased DNA synthesis, such as in dysplastic and neoplastic cells. So the procedure is, the first one, we have to rinse mouth with water for 20 seconds twice to remove the debris, and then rinse mouth with 1% acetic acid solution for 20 seconds to remove saliva, and then dry the area. Apply the toluidine blue dye to the high-risk areas of the lesion, and then rinse with 1% acetic acid for 1 minute to clear the excess stain. Rinse with water, and finally we can assess the color change. So for the interpretation, if the lesion appears dark royal blue, then it is positive. But if there is no color, then it is negative. It is doubtful if it is light blue, and it can give false positive results in epithelial hyperplasia, hyperkeratotic lesions, inflammatory and traumatic lesions. And usually the clinician will repeat the test after 10 to 14 days. And it can also give the false negative results, which can be seen in low-grade dysplasia and lichenoid dysplasia. The advantages of toluidine blue staining is it is inexpensive and simple. It is used for screening high-risk patients who may have asymptomatic malignant lesions of oral cavity. It is helpful for surgeons to evaluate free surgical margins, and it does not interfere with histologic staining or interpretation. The disadvantages of toluidine blue staining is it often gives false positive and false negative results. Filiform papillae retain dye due to high protein synthesis rate, and it stains only 3 to 4 cells deep, which means that it is limited to epithelium. Invaded underlying tissue is not penetrated by dye, hence difficult to appreciate the submucosal spread. So moving on to the next test, which is the Schirmer's test. The uses of the Schirmer's test is to record measurement of tear secretion in patients with suspected dry eyes. It confirms and determines the severity of dry eye, and along with other tests, it helps to diagnose Sjogren's syndrome. So there are two variations of Schirmer tests, which are the first one, the Schirmer one, which is done without anesthetic, and it measures the total tear secretion, both basal and reflex secretion. And the second variation is the Schirmer 2, which is done with anesthetic, and it measures the basal secretion. So, to do the Schirmer's test, first we have to bend the Schirmer's test strip to a 90-degree angle and ask patient to look up, and with our index finger, gently pull down the lower eyelids. Hook the bent end of the strip over the center of the lower eyelids and allow them to sit inside. Ask patient not to squeeze, but just keep the eyes gently closed. And finally, remove the strips after 5 minutes and measure the length of the moistened area on the strips. So for interpretation of Schirmer's test after 5 minutes, The patient may be normal if the wetting area is more than 10 millimeter. The patient may have moderate to mild dry eyes if the wetting area is around 5 to 10 millimeter, and they might have severe dry eyes if the wetting area is less than 5 millimeter. So for advantage of Sherman test, it is simple and there is no known risk. However, the disadvantages are it has high variability, low reproducibility, and it has potential for evaporative loss.
Next, as one of the extended learning topics, I'm going to talk about biopsy. Here are the major types of biopsy routinely used in and around oral cavity, which are for cytology. We have exfoliative cytology and brush biopsy. Second, aspiration biopsy. Third, incisional biopsy. Fourth, excisional biopsy. And fifth, punch biopsy. The first one is exfoliative cytology and brush biopsy. It is a microscopic examination of shed desquamated cells from body surfaces or cells harvested by rubbing or brushing a lesional tissue surface. It also includes cells harvested from mucous membranes and body fluid. The armamentarium for this biopsy, it requires microscopic slides stored in container, cell harvesting instrument such as wooden spatula, metal spatula, and cytobrush, and it also requires fixative such as pus stain, pap stain, gram staining, and others. The procedure is by using suitable wet instruments is vigorously scrape or brush against the lesion in one direction. Next, scraping or brush are spread evenly and rapidly over an empty slice. Specimens is fixed with papanicolo or gram staining, pus staining, or HNA stain, and it is studied under microscope. The imputation of the exfoliative cytology, class 1, indicates normal, which only normal cells are observed. Class 2 indicates atypical lesion, where there is presence of minor atypia due to inflammation and there is no signs of malignancy. Class 3 indicates intermediate lesion, where we can see wider atypia suggestive of severe dysplasia, carcinoma in situ or cancer. Class 4 suggestive of cancer, which shows few epithelial cells with malignant changes. Here, biopsy is mandatory. Class 5 is positive for cancer, where the cells show characteristic malignant changes, such as invasion into connective tissue. Here, biopsy is also mandatory. Thus, Class 4 and Class 5 is mandatory for biopsy. The advantages of exfoliative cytology and brush biopsy is it is non-invasive and painless. We can require patient compliance, and it is cost-effective. However, there is also disadvantages, which is false negative results. It has low sensitivity and it is not usable in non-epithelial lesion. It only used in epithelial lesion. Next is aspiration cytology, also widely known as fine needle aspiration cytology. It is a diagnostic technique involving collection and evaluation of cells obtained from a thin gauge needles. For example, from a cyst like OKC, DC, as well as a salivary gland lesion like mucocele and ranula, where it consists of fluid in the lesion. So we use aspiration cytology to diagnose a fluid-filled lesion. The armamentarium needed is alcohol swab, small gauge needle, glass slides, as well as fixative. The procedure, the first one is palpate the lesion, clean with spirit swab from center upwards in concentric fashion, and leave to dry. Prick the lump by vertical technique and aspirate the lump by pulling the piston. Rotate the needle and continue to aspirate. Move it back and forth and aspirate. Prepare the smear and examine under microscope. The advantages of aspiration cytology, it is easy to perform and less invasive. And then the cyst can be aspirated easily and diagnosed with this procedure, and it is a cost-effective procedure. As for incisional biopsy, I will tell the difference between incisional biopsy, excisional biopsy as well as punch biopsy. For incisional biopsy, it is a type of biopsy that examines only a representative part of the lesion. The indication is when the lesion is large, more than 1 centimeter in diameter, when the lesion is located in a risky or hazardous location, or whenever a definitive histopathologic diagnosis is desired before planning a complex removal or other treatment. As we can see in the pictures at the right, on the pictures on top shows where the lesion has to be excised, and the picture at the bottom shows the lesion after the excision. So we excise only a part of the lesion. Meanwhile, for excisional biopsy, it is the removable of the entire lesion at the time that the diagnostic procedure has been performed. So it is a total removal. The indication for excisional biopsy is when the lesion is small, less than 1 centimeter in diameter, and clinically appear benign. For example, one of the treatment for mucocele. And when complete excision will not compromise patient feature or oral function, lesion must be removed entirely to treat patient well-being. And then the punch biopsy is basically an alternative technique of tissue removal applicable for both incisional and excisional biopsy. Punch biopsy is available in various sizes, and the resultant defect is an open wound which must be healed by a secondary healing. Next, I'm going to talk about the difference between pus stain as well as pap stain. Pus stain is known as periodic acid shift stain, and pap stain is known as Papanicolaou stain. So, periodic acid shift stain is a special staining technique which is used to highlight molecules with high percentage of carbohydrates. Meanwhile, Papanicolaou stain is a multichromic staining histological technique. This is developed by George Papanicolaou. It is used to differentiate cells in smear preparation of various bodily secretions. The example when we are using periodic acid shift stain is when we want to stain for mucin, glycogen, fungus, basement membrane of the skin. And for Papanicolaou stain is used to stain smear preparation in various bodily secretions such as gynecological smears, pap smears, sputum, fine needle aspiration fluid. The principle of periodic acid shift is it works by exposing the tissue to periodic acid, and this periodic acid will act as an oxidizing agent which will oxidize compound having free hydroxyl group or amino or alkyl imine group, resulting in the formation of dialdehydes. And these dialdehydes, when exposed to shift reagent, will form an insoluble magenta colored complex. And it is different with Papanicolaou stain because it has 5 dyes in 3 solutions. So the first dye is a nuclear stain, which is also known as hematoxylin. It is used to stain cell nuclei. And the second one, we have OG6 counter stain, which is the orange G, is used to stain keratin. Its original role was to stain the small cells of keratinizing squamous cell carcinoma present in sputum. And the second, eosin azure counter stain, it consists of another 3 dyes, which is denotes by the proportion of the dyes such as EA50 and EA65. But it is called as eosin Y as well as light green SF, yellowish stain. So eosin Y, which stains the superficial epithelial squamous cell, nucleoli, cilia as well as red blood cell. And light green SF yellowish stain will stain the cytoplasm of all the other cells. The results for periodic acid shift has variable, which is it can show a positive staining which is a normal one, positive staining of a diseased lesion, and a negative staining. Positive staining for a normal lesion is it can stain basement membrane, fungus, glycogens, mucins as well as surfactant. And positive staining, which indicates for disease, it can show staining for basement membrane containing tumors such as cylindroma, clear cell tumors, renal cell carcinoma. And negative staining shows mucin of acid simple mesenchymal and acid complex connective tissue types. As for the result for Papanicolo stain, it stains ribosome blue-green, it stains metabolically inactive cells pink, such as superficial cells, and it stains keratinized cell or thick specimen orange, which can indicate benign or malignant lesion.
Alright, so we move on to plain radiographs. X-rays can detect problems that would be missed by just looking in your oral cavity, such as an infection in your tooth or tooth root, cavities or caries between teeth or under fillings, trouble with teeth and jaw development in children and teens who are getting their permanent teeth, and also bone loss from severe gum disease. There are many different types of dental radiographs which can be taken to view different aspects of the teeth and jaw bones. Firstly, there are intraoral radiographs such as intraoral periapical radiograph, which is also known as IUPA, bite-wing radiograph, and also occlusal radiograph, whereas in extraoral radiograph there is panoramic radiograph or orthopantomogram, which is also known as OPG, and also lateral cephalometric radiograph. So firstly, we'll start off with the IUPA radiograph. The IUPA helps the dentist to observe conditions below the gum line, showing the roots of the teeth. It can be taken of anterior or posterior teeth and focuses on 2 complete teeth from the root to the crown. A few uses of the IUPA radiograph includes in apical lesions, cyst and apical surgery, endodontic treatment, and also implant prosthesis. It can also be used in detecting dental caries and analyzing mixed dentition. IUPA is also used in pulp pathology or also to analyze the periodontal status. It is also used in cases of trauma and unerupted tooth. So here are some examples of the resultant IUPA radiograph taken in different aspects or different parts of the dentition. As you can see from the pictures, it shows the main radiographic features indicated in the maxillary arch. For the first picture is for the maxillary incisors, the second for the maxillary canines, the third for the premolars, and the fourth for the molars. Next, these are also some examples of the resultant IUPA radiographs, but in the mandibular arch. So the first picture shows the mandibular incisors, the second shows the main radiographic features in the canines, the third in the mandibular premolars, and the fourth in the mandibular molars. As you can see, the radiographs here are labeled, which shows how IUPA helps to identify important structures and landmarks in a tooth and also helps in identifying the pathologies in a tooth as explained earlier. Next is the bite-wing radiograph. Bite-wing radiographs are indicated primarily to detect or monitor interproximal caries if the proximal surfaces of the teeth cannot be visually or tactilely examined. These are taken with a small film or digital sensor that you will bite with your posterior teeth. Occlusal caries, crestal areolar bone level, and secondarily for eruption patterns, caries and restoration proximity to pulp spaces, primary molar furcation pathology, and developmental anomalies may also be detected with bite-wing radiographs. The frequency of bite-wing radiographic examination is based on caries risk assessment. As the risk status may change over time, the radiographic recall interval may change. A patient with a high caries risk assessment will require bite-wing radiographs more often, which is around every 6 months, than a patient with a low caries risk assessment, which is around 12 to 24 months. Some of the uses of the bite-wing radiograph include detection of lesion of caries, monitoring the progression of dental caries, and also to assess existing restorations or the periodontal status. As you can see in the picture beside it, it shows a bite-wing radiograph which shows a caries lesion. Next, we move on to the procedure of how to take a bite-wing radiograph. The desired holder is selected together with an appropriate size image receptor, typically a 31 x 41 mm film packet or phosphor plate, or the equivalent size solid-state sensor. The patient is positioned with the head supported and with the occlusal plane horizontal. The holder is inserted carefully into the lingual sulcus opposite the posterior teeth. The interior edge of the image receptor should be positioned opposite the distal aspect of the lower canine. In this position, the image receptor extends usually just beyond the mesial aspect of the lower third molar. As you can see in the figure A, it is the position of the simple Hohenhu's quick bite holder in relation to the teeth. Next, the patient is asked to close the teeth firmly together onto the bite platform. Please note that the extra care is needed to be taken of solid-state sensor cables. The X-ray tube head is aligned accurately using the beam aiming device to achieve optimal horizontal and vertical angulations as seen in Figure B. Figure B shows the position of the Hohenhu's quick bite holder with the circular beam aiming device in relation to the teeth. Next, we move on to the occlusal radiograph. This X-ray is done when your jaw is closed to see how your maxillary and mandibular teeth line up. It can also detect anatomical abnormalities with the floor of the mouth or the palate. This technique captures all your teeth in one shot. Some of the uses of the occlusal radiograph include periopical assessment of the upper anterior teeth, especially in children, but also in adults that are unable to tolerate periopical holders. It is also used to detect the presence of unerupted canines, supernumeraries, and odontomes. In the midline view, it is used for determining the buccal or palatal position of unerupted canines. It is also used to evaluate the size and extent of lesions, such as cysts or tumors in the interior maxilla. Lastly, it is also used to assess the fractures of anterior teeth and alveolar bones. Next, we move on to the procedure. The patient is seated with the head supported and with the occlusal plane horizontal and parallel to the floor and is asked to support a protective thyroid shield. The image receptor, suitably barrier wrapped, is placed flat into the mouth onto the occlusal surface of the lower teeth. The patient is asked to bite together gently. The image receptor is placed centrally in the mouth with its long axis crossway in adults and anterior-posteriorly in children. The X-ray tube head is positioned above the patient in the midline, aiming downwards towards the bridge of the nose at an angle of 65 to 70 degrees to the image receptor. As you can see in the images, it is explained how an occlusal radiograph is taken. The picture in A shows a diagram showing the position of the image receptor in relation to the lower arch. In B, it shows the positioning from the front, and note that the use of the protective thyroid shield. C is the positioning of the patient from the side, and D shows a diagram of the positioning from the side. This is an example of an upper standard occlusal radiograph with the main anatomical features indicated. Besides that, we also have extraoral radiographs such as the panoramic radiograph, which is also known as OPG. It is a two-dimensional dental X-ray examination that captures the entire mouth in a single image, including the teeth, upper and lower jaws, surrounding structures, and tissues. Unlike a traditional intraoral X-ray, where the film or X-ray detector is placed inside of the mouth, the film for a panoramic X-ray is contained inside of the machine. The jaw is a curved structure, similar to that of a horseshoe. However, the panoramic X-ray produces a flat image of the curved structure. It usually provides details of the bones and teeth. Some of the uses of and OPG X-ray include in advanced periodontal disease, cysts in the jaw bones, jaw tumors, and oral cancer. It's also used in infected teeth, including wisdom teeth, and jaw disorders. The OPG provides valuable information about the maxillary sinuses, and is also used in tooth positioning and other bone abnormalities. OPG also helps in planning treatment for full and partial dentures, braces, extractions, and implants. Next is a procedure on how OPG is taken. During a panoramic X-ray examination, the X-ray tube rotates in a semicircle around the patient's head, starting at one side of the jaw and ending at the other side. Rather than relying on film placed inside the mouth, a panoramic X-ray machine projects a beam through the patient onto film or a detector rotating opposite the X-ray tube. First, the patient will be situated in the center of the unit, where the technician will carefully position and secure the head. A bite blocker is then placed in the patient's mouth to ensure proper alignment of the teeth. Most X-ray images are digital files that are stored electronically. These stored images are easily accessible for diagnosis and disease management. The digital format also allows the dentist to adjust and change the contrast, brightness, and darkness of the image for better visualization of certain structures and tissues. Images on film cannot be adjusted or changed. So here's an example of an OPG taken. As you can see, there are wisdom tooth present, which hasn't erupted. Next is the lateral cephalometric radiograph. Cephalometric radiography is a standardized and reproducible form of skull radiography used extensively in orthodontics to assess the relationship of the teeth to the jaws and the jaws to the rest of the facial skeleton. Standardization was essential for the development of cephalometry. The measurement and comparison of specific points, distances, and lines within the facial skeleton, which is now an integral part of orthodontic assessment. The greatest value is probably obtained from these radiographs if they are traced or digitized, and this is essential when they are being used for the monitoring of treatment progress. The goals of cephalometric is to evaluate the relationship both horizontally and vertically of the 5 major functional components of the face, which includes the cranium and the cranial base, the skeletal maxilla, the skeletal mandible, the maxillary dentition and the alveolar process, the mandibular dentition and the alveolar process. This is a picture shown of the parameters of the important landmarks seen in cephalometric radiographs. Next, moving on to the uses. Lateral cephalometric radiographs are used in orthodontic diagnosis and planning. It is also used in orthodontic evaluation, treatment planning, and results. It also classifies skeletal and dental abnormalities and establishing facial types. It is also used to evaluate treatment results and predict growth-related changes and changes associated with surgical treatment. It is a valuable aid in research work involving the cranio-dental-facial region. If we move on to the advanced imaging techniques, one of it being the CT scan. Computed tomography, which is also known as CT, of the body uses sophisticated X-ray technology to help detect a variety of disease and conditions. The cross-sectional images generated during a CT scan can be reformatted in multiple planes. They can even generate 3-dimensional images. CT images of internal organs, bones, soft tissues, and blood vessels provide greater detail than traditional X-rays, particularly of soft tissues and blood vessels. The CT scanner is typically a large donut-shaped machine with a short tunnel in the center. The computer workstation that processes the imaging information is located in a separate control room. This is where the technologist operates the scanner and monitors your exam in direct visual contact. As you can see in the pictures, this is an illustration of how a CT scan looks like. Next, how does a CT scan work? In many ways, a CT scan works like any other X-ray exams. Different body parts absorb X-rays in different amounts. This difference allows to distinguish body parts from one another on an X-ray or CT image. As usual, bones appear white on X-ray, Soft tissues, such as heart or liver, shows up in shades of gray, and air appears black. With CT scanning, several X-ray beams and electronic X-ray detectors rotate around you. A special computer program processes this large volume of data to create two-dimensional cross-sectional images of your body and are then displayed on a monitor. When the image slices are reassembled by computer software, the result is a very detailed multi-dimensional view of the body's interior. For some CT exams, a contrast material is used to enhance the visibility in the area of the body being studied. Next is the uses of CT scan. It quickly identifies injuries in case of trauma. It also guides biopsies and other procedures such as abscess drainage and minimally invasive tumor treatments. It is also used to plan for and assess the results of surgery such as organ transplants or gastric bypass. It is also used to stage, plan, and properly administer radiation treatments for tumors as well as monitor response to chemotherapy. Next, it is also used to measure bone mineral density for the detection of osteoporosis. CT is also commonly used to assess for pulmonary embolism, which is a blood clot in the lung vessels, as well as for aortic aneurysms. Often, the best method for detecting cancers as to confirm the presence of a tumor is through a CT scan, which is to measure its size, identify its precise location, and determine the extent of its involvement with other nearby tissues. Next is the procedure on how a CT scan is taken. The patient is positioned on the CT exam table, usually lying flat on the back. Straps and pillow may be used to help maintain the correct position and remain still during the exam. If a contrast material is used, depending on the type of exam, it will be swallowed, injected through an intravenous line, or rarely administered through the rectum. The table will move quickly through the scanner to determine the correct starting position for the scans. Then, the table will move slowly through the machine as the actual CT scanning is performed. Depending on the type of CT scan, the machine may take several passes. The CT examination is usually completed within 30 minutes. The position requiring intravenous contrast injection usually lasts around only 10 to 30 seconds. We also have the CBCT scan, which is known as cone beam computed tomography. This technology takes a series of images to create a 3D image. It is based on a cone-shaped X-ray beam centered on a 2D detector that performs one rotation around the object, producing a series of 2D images. These images are then reconstructed in 3D using a modification of the original cone beam algorithm. Because it relies on multiple images, the radiation exposure is higher than that of commonly used X-rays. It is used when more detailed information is needed. Images of the craniofacial region are often collected with a higher resolution than those collected with a conventional CT. Here are some examples of how a CBCT scan looks like, and the image below shows the resultant CBCT scan taken. Some of the uses of a CBCT scan include in surgical planning for infected teeth, diagnosing TMJ disorders, and also the accurate placement of dental implants. It can also be used to evaluate the jaws, sinuses, nerve canals, and the nasal cavity. It is also used in detecting, measuring, and treating jaw tumors. CBCT scan also determines bone structure and tooth orientation. It is also used to locate the origin of pain or pathology. Next, it is also used in cephalometric analysis and also reconstructive surgery. During a cone beam CT examination, the C-arm or gantry rotates around the head in a complete 360 degrees rotation while capturing multiple images from different angles that are reconstructed to create a single 3D image. The X-ray source and detector are mounted on opposite sides of the revolving C-arm or gantry and rotate in unison. In single rotation, the detector can generate anywhere between 150 to 200 high-resolution 2D images which are then digitally combined to form a 3D image that can provide information about oral and craniofacial health. So the procedure of how a CBCT scan is taken is the patient is asked to sit in the exam chair or lie down on the exam table, depending on the type of cone beam CT scanner being used, positioning the area of interest centered in the beam. The patient is then asked to remain very still while the X-ray source and detector revolves around for a 360-degree rotation or less. This typically can take between 20 to 40 seconds for a complete volume, also called a full mouth X-ray, in which the entire mouth and dental structures are imaged, and less than 10 seconds for a regional scan that focuses on a specific area of the maxilla or mandible.
I'm going to be talking about MRI, which is also known as nuclear magnetic resonance imaging, which is a scanning technique for creating visual images of human body. It strongly uses magnetic field, which is about 0.2 to 3 Tesla, or 1,000 times the strength of a fridge magnet, and radio waves to generate images of parts of body that cannot be seen with X-ray, CT scans, or ultrasound. It also helps the doctors to see joints, cartilages, ligaments, tendons, and also it helps for detecting various sports injuries. MRI is also used to examine the internal body structures and diagnose a variety of disorders such as stroke, tumor, aneurysms, spinal cord injuries, and multiple sclerosis. How does the procedure work? MRI does not use radiation. Instead, it uses radio waves that realign hydrogen atoms that naturally exist within your body. It does not cause any chemical changes in the tissue. As hydrogen atom returns to the usual alignment, they emit different amount of energy depending on the type of body tissue they are in. The scanner captures the energy and creates a picture using this information. In most MRI units, the magnetic field is produced by passing electric current through the wires. Other coils are located in the machine and in some cases are placed around the parts of body being imaged. These coils send and receive radio waves producing signals that are detected by a machine. The electric current does not come in contact with the patient. Then a computer processes the signals and creates a series of images, each of which shows a thin slice of body. These images can be studied from different angles by a radiologist. MRI is able to tell the difference between diseased tissue and normal tissue better than X-ray, CT scan, and ultrasound. This is an example of how an MRI machine looks like. I'm sure most of you didn't know that MRI is also used in dentistry. It is used to enable soft and hard tissue imaging. It is also used in diagnosing of temporomandibular joint disorder, soft tissue pathology, bone topography for placement of dental implants. Some MRI sequences were shown to provide fast and soft hard tissue imaging of hydrogen, which increases the interest in dental MRI. Recently, MRI allowed direct visualization of cancellous bone, intraoral mucosa, and dental pulp. Despite that, cortical bone and dental roots are indirectly visualized. This is an example of how a plate will look like under MRI. The advantages and disadvantages of MRI. The advantages are it is non-invasive and there is no detrimental effect as it uses non-ionizing radiation. It helps to differentiate soft tissue from one another due to the contrast resolution, and it also produces multi-planar images such as sagittal, coronal, and oblique. It is safe to use in pregnant ladies and children. Lastly, artifacts with dental fillings are not seen. Moving to the disadvantages, claustrophobia. If you are claustrophobic, you can ask for mild sedative from the consultant to make you feel better. And it is expensive and very noisy. It is contraindicated in patients with cardiac pacemakers, implantable defibrillators, and metallic implants, as MRI uses a very strong magnetic force, so it can cause injury if you are having any metallic implants. Next, bone marrow gives signal but not bone. And lastly, distinction between malignant and benign tumors are difficult. Next, I'm going to be talking about skeletal scintigraphy. Skeletal scintigraphy uses small amounts of radioactive material to diagnose and assess the severity of a variety of bone disease and conditions, including fracture, infection, and cancer. Nuclear medicine imaging procedures are non-invasive and with the exception of intravenous injection. This imaging scan uses radioactive material called radiopharmaceuticals and radiotracers. The example of radiotracer used in skeletal scintigraphy is technetium. They have potential to identify disease in its earliest stage as well as patients' response to therapeutic intervention. In fact, a bone scan can often find a bone abnormality much earlier than a regular X-ray exam. The uses of skeletal scintigraphy is it is used in finding of bone cancer or to determine whether a cancer from another area of the body such as the breast, lung, or prostate gland has spread to the bones. It is also used in diagnosing the cause or location of unexplained bone pain. It is used in diagnosing broken bones which are not clearly seen in the X-ray, and it is also used in finding bone damage caused by infection or other conditions such as Paget's disease. How is skeletal scintigraphy performed? It begins with the injection of radioactive substances into your vein. The substance is then allowed to work its way through your body for the next 2 to 4 hours. As the substance spreads through your body, the bone cells naturally gravitate to areas that need repair. The substance radioactive tracer follow these cells and collect in spots where the bone is damaged. It is taken up in regions that have high blood flow, and after enough time has passed, the doctor will use special camera to scan the bones. These damaged areas where the substance has settled appear dark spots on the image. Okay, next I'm going to be talking about autofluorescence. What is autofluorescence? Autofluorescence is when a cell interacts with light of a particular wavelength, they become excited and they re-emit the light of a varying wavelength, which is called as autofluorescence. Autofluorescence of tissue is produced by fluorophores that naturally occurs in most human tissues. Naturally occurring fluorophores are collagen, tryptophan, elastin, keratin, hemoglobin, and NADH. Potentially malignant disorder and cancerous conditions cause a change in the concentration of these fluorophores. They cause alteration in the natural light scattering and absorption properties of the tissue. Changes in the spectral property of mucosa can be detected and can be used as a tool in diagnosing the potentially malignant disorder and cancerous condition. The major advantage of fluorescence technique is they are non-invasive procedures that can be minimized in the need of unnecessary biopsy. And they can be performed on medically compromised patients who are contraindicated for biopsies. They can be also performed as in vivo chairside procedure, which can be used to define surgical margins of the lesions. They can also be used as a tool in mass screening procedures. Autofluorescence is also used in oral neoplastic tissues. The autofluorescence property of oral mucosa depends upon the anatomic location and the type of lesion that occurs on it. In the normal mucosa, fluorescence in the ultraviolet and visible region of the spectrum is predominantly due to the collagen that is present in the connective tissue. The epithelium always shows weak autofluorescence due to the mitochondrial LADH and MAD present in the basal cells of the epithelium. Keratin present in the epithelium also produces fluorescence, whereas neoplasia causes loss of stromal collagen, which leads to the loss of autofluorescence, as you can see in the picture below. Epithelial dysplasia increases mitochondrial fluorescence of the epithelium. Loss of both epithelial and stromal autofluorescence is observed in the inflammatory lesion. This picture shows how cancerous, precancerous, and normal buccal mucosa look like when it's viewed under the autofluorescence. As you can see, neoplastic lesion appears in a darker shade of green compared to the normal mucosa. That's all from us. These are the references that we use. This is the Socrates code. Thank you.